Good morning. This is the voiceover PowerPoint for Chapter 20, which we have already covered, but I hope I have some new information possibly for you. We're going to look at our slow number 1, and we are talking primarily about chapters 20 and also 28. So chapter 20 covers slows 1, 2, 3, and 4. Chapter 28 covers slows 5, 6, 7, and 8 for theory number 5. Okay, so there are many changes that occur after a laboring woman has her baby. And the one that we need to talk about and really focus on here is what's called the involution of the uterus, which just basically means that the uterus goes back to its pre-pregnant state. So while I'm thinking of it, we're talking about involution. So let's just stop here for a second and let's cover some important things that happen a little bit before this begins. The postpartum period begins after the delivery of the placenta, and it lasts until these organs, these reproductive organs, return to the pre-pregnant state, usually 6 to 8 weeks. The first hours after delivery can be termed the 4th stage of labor. We don't hear that talked about a lot, but it is very true. The placenta begins to separate, as you know, shortly after the baby is born. The doctor may massage the fundus, trying to get it to kind of start coming away from the uterine wall, and uterine contractions help shear off that placenta off the wall, and usually it's a very efficient process. Most of the time there is no issue as far as retained products of conception, retained placenta, etc., but we always have to be aware that that's a possibility. And so what happens is the placenta shears away from the wall, and there are 4 classic signs that you need to be aware of. 4 classic signs of placental separation. Number 1, the umbilical cord gets longer. It already is protruding from the vagina, and it has been cut. The baby's cord has been cut and clamped and then cut. Is how we do it. And then the remainder of the umbilical cord, is protruding from the vagina. And then as the placenta starts to separate, it makes sense that more and more of that length of cord will become longer. There will also be a gush of blood. That is not necessarily problematic if the fundus is firm, and that's why the doc will massage that fundus a little bit, push on it a little bit to try to get that placenta out. And there's usually a little bit of blood kind of behind that placenta as it separates, and so that's the gush of blood. The uterus becomes more globular in shape, and it will rise in the abdomen. So let's remember too that sometimes multiparous women who've had more than one baby will have another second gush of blood afterwards. But again, we just want to keep a close eye on those kind of things. So the umbilical cord, the placenta is expelled, and the doctor will inspect it, or the practitioner, whoever that might be, will inspect it for any pieces that might be missing. They want to make sure that it's all intact. Okay. All right. Now, some other interesting physiologic changes that occur immediately following birth, and this is something that is good to know as far as taking care of your patient, and then there's some other facts that we'll talk about as well. So one thing that happens in about 25 to 50% of women the first 30 minutes after birth is they are shivering, they are freezing, they feel like that you can actually see they're shivering, quite obvious. And lots of times this is just as a result of hormone shifts, fluid shifts, all the things that are happening during birth. And so what we need to do is most delivery rooms or delivery areas have a blanket warmer, and the best thing we can do is go grab one of those nice warm blankets, put it right next to her, tuck it in all around her as much as we can, and that usually does the trick. So as far as blood loss in women after delivery, usually for a vaginal birth, we say less than 500 milliliters. For a cesarean section, usually less than 1,000 milliliters. Okay. And again, like we said a while ago, the multiparous woman will tend to have 1 to 3 more episodes of sudden gush of blood with a firm fundus within 20 to 30 minutes. That makes sense because that uterus has been stretched more than once, and it will take it a little longer to come back down to where it was pre-pregnant. Also remember that the first hour postpartum is a critical, this is very, very important, critical time period because there's happening all kinds of hormone raging going on. It's a very sensitive time. We call it the golden hour when that mother and infant attachment can be strongly affected. The first 24 hours is the immediate postpartum period, and then the 3 months after delivery, like we said earlier, are termed the 4th trimester or the 4th stage, if you will. But I'm more concerned about that sensitive time, that first few hours, that first 24 hours really is very, very important in watching for postpartum hemorrhage, watching for any other complications, and making sure that mama and that baby have time together undisturbed so that they can bond and form that attachment. So, of course, our goal of postpartum nursing care is to provide a safe and transition of physiologic things from pregnant to non-pregnant. We want to make sure we address their discomfort and their pain. We want to provide a supportive environment for the maternal-infant attachment. We want to have a supportive environment for family transition. And a little later in the process, we may be a part of helping that woman access resources that she may need. And of course, one thing we're going to make sure is we're going to pull in our social worker and discharge planner when we need them. Okay, we talked in class about the hemoglobin and hematocrit, how it can fluctuate a little bit, and it will drop a little bit because we talked about that physiologic anemia and that hemodilution with all that volume that the pregnant woman has. And what we will need to remember is as she is delivering, a lot of that volume is removed, and so her hemoglobin and hematocrit no longer will be dilutional. It will be more closely to normal, and so it may drop a little bit by day 2, but it usually returns to normal in 1 week. Now remember, most pregnant women are fairly healthy, so if they have a hemoglobin of instead of 14, it's 12, that does not mean they are anemic. We don't consider anybody anemic really until they're below 10, and so we want to keep those numbers in mind. 12 to 14 is where we want it, of course. But if it fluctuates a little bit and then goes back up, we're just going to keep an eye on it. Sometimes the white blood cell is elevated during labor and begins to decline at postpartum. Sometimes the white count can be 20 to 25,000. That does not necessarily mean there is a raging infection. We want to make sure that we look at other signs. We don't just look at numbers. Now, if your woman she has had premature rupture membranes for several days, and she's running fever and she feels bad, and you look at her white count and it's elevated, whole different story. But we're talking about a postpartum woman with no complications, no premature rupture membranes, no issues during delivery. She will have a transient elevation in white blood cell count that we just need to be aware of and keep an eye on that. The hemoglobin, hematocrit, and WBC values are not reliably reflective of anemia or infection in the first few days. Let me repeat that. Hemoglobin, hematocrit, and white blood cell values are not reliably reflective. In other words, they're not an actual true picture, possibly, of anemia or infection in that first few days. All right. Now, we're also going to keep an eye on platelets, of course, fibrinogen levels, and remember that pregnancy is hypercoagulable state, which means they're more prone to clots. And if these fibrinogen levels, which is a big indicator of possible clotting and so forth, returns to the pre-pregnant values by 2 to 3 weeks, but they are still at risk for thrombosis until about 6 weeks postpartum. So we need to be watchful of that, and we need to instruct them, teach them the signs and symptoms of possibly a venous thrombosis. Okay, and then we also have to be aware that even though the treatment for preeclampsia is delivering the baby, women can actually continue to have problems with preeclampsia following childbirth. So we have to be aware of the blood pressure, that bad headache, epigastric pain, and so forth. And we will keep an eye on those, excuse me, those vital signs, which is and we were going to do that anyway, right? Okay, so let's go back to our slide here and talk about involution of the uterus, okay? And you can see here that the side of the placental attachment heals by process of exfoliation, and it should leave the endometrium or the inner lining smooth and without scars. Okay. We are going to evaluate involution by measuring with our finger breadths. Remember the finger breadths, determining the height of the fundus after delivery. We are going to measure that by measuring the descent or the involution of the fundus. At delivery, we should palpate the fundus, the top of the fundus, right at the umbilicus or the belly button or umbilicus, however you want to say it. It's all correct. When, if it's above and it's not firm, then absolutely we need to investigate what's going on here. We're going to massage that fundus. We're going to check the status of that bladder. How long has she been without, since she's voided or urinated or calved, whatever the situation is. That's the number one reason that we have a boggy fundus, is the bladder is often full. All right. About 1 centimeter per day or 1 finger breadth per day, it should go down. So at delivery, we considered it at U, which is at the umbilicus, and then as it goes down, it would be U minus 1, U minus 2, U minus 3. Okay, we go everything from the umbilicus up or down. All right. 14 days after childbirth, it should no longer be palpable if it's involuting or going back to its pre-pregnant state accordingly. All right. After pains or intermittent uterine contractions often cause discomfort. They're like really bad menstrual cramps, okay? This is very common in your multiparous woman, your woman who's had more than one baby. Also, breastfeeding, because it releases prolactin and oxytocin, can stimulates breastfeeding. That also stimulates the uterus to contract, and so they're going to have some after pains. And so what we do is we hand them some ibuprofen or maybe some Tylenol or alternate the two. All right. Okay, so this is just a picture of how the uterus involutes, and you see here by about day 9, it's getting pretty far down, and you probably won't be able to feel it even then, but by 2 weeks, it should be all the way back down to what it was like before pregnancy. Now let's talk about lochia, or the discharge that women have after postpartum, at postpartum, excuse me. This is from your book. You should be able to read this and review this on your own. Day 1 to 3, we have lochia rubra, okay, red, dark red. There's a little maybe a hint of brown. It's bloody and may have a few little small clots. It smells like blood. I mean, it's not necessarily unpleasant or foul. It just has a very distinct odor, and that's normal. Large clots, saturated pads, foul odor would not be normal. All right. Day 4 to 10, the lochia changes to lochia serosa, excuse me. So serous is that straw-colored fluid, the serum in the bloodstream, and then sanguineous, okay, is the blood, and so it's kind of a mixture. It's a decreasing in amount, should be. It can be kind of pinkish or brown tinged. If it's excessive amount, there's a foul odor. and there's still a lot of red color to it. That is not normal. And then day 11 to 21 or 28, there's different days on there. Who really cares? We have the lochia alba, okay? May last up until the 6th week, as you see here. A decreasing amount kind of becomes a whitish, yellowish kind of color. It's, huge, should not be a huge amount. Most of the time, women just have to wear some sort of a panty liner, not necessarily a full pad. And then you see the abnormal on the other side there. Okay? You've seen this before. This should not be anything that you do not know anything about. And these are not exact. We don't measure 1 to 4 inch. We don't do that. As you get more experienced in your practice, if you decide to be an OBGYN nurse, then you'll get very, very, very good with this. Now, the saturated pad, that's pretty obvious. It fills the whole pad, and when you pick the pad up, it feels heavier than it did when it was dry. So that would be something that we would be very concerned about. Saturating a pad in 1 hour, very concerning. Now, they saturate it in 1 hour, and then later it kind of stops, drops off a little. That's a different story, but you have to evaluate very carefully. Other changes in the postpartum woman, the vagina takes about 6 to 10 weeks for it to regain its non-pregnant size and contour. The perineum itself, that goes, from all the way up from the top of the mons pubis all the way through to the rectum. After childbirth, it can be edematous and bruised in appearance. Not unusual in that first few hours. If there's an episiotomy or trauma, like lacerations, I want you to remember you have the 1st, 2nd, and 3rd degree and 4th degree lacerations. We'll see those in just a minute. Healing of the perineum takes about 4 to 6 months completely. Okay, and so your patient will let you know about that for sure. Okay. Other things that happen postpartum. The ligaments that were overstretched during pregnancy, that's why it will allow it to shift from side to side and in accordance with the healing, with a full bladder, excuse me. And so we'll be talking about that in just a minute. Okay, so here's your lacerations of the birth canal. That's the entire vagina. Okay, the birth canal is the entire vagina, all the way from the cervix to the opening. All right. So the perineal lacerations are classified as 1st, 2nd, 3rd, and 4th degree. You need to remember these, okay? Because obviously the bigger the number, the more damage, if you will, or trauma that the woman has. Now, if she has a 3rd or a 4th degree laceration, she is going to have difficulty sitting. She may sit to one side. We do not recommend that they sit on donuts, the inflatable things. Don't do that. That doesn't really help. Maybe some foam pads, possibly. It depends on what she wants. Also, remember 3rd and 4th degree lacerations are very painful, and it's very often very traumatic, the first bowel movement, especially if she's a little constipated. It can be excruciatingly painful, okay? The periurethral area can also be lacerated. She may have difficulty urinating after birth. If it's very significant periurethral laceration, they may actually leave a Foley catheter in for a few days. The vaginal wall lacerations can occur, and then the cervix can be lacerated as well. And so what the doc will do, or the healthcare provider will do, is they have a speculum that opens, and they can look in there and see what they need to sew up. Sometimes 1st degree lacerations are not sutured. They will just be allowed to close on their own. It just depends on how significant it is, and maybe healthcare provider preference. Okay, let's see. The cardiovascular system. Remember, we talked about the extra volume that they have during pregnancy to account for the baby and the amniotic fluid and so forth. The excess volume is eliminated by diuresis and diaphoresis. Those are key things to remember, that this excess plasma volume that they've been carrying around now is no longer needed. It's eliminated by diuresis. So they're going to, the first couple of days, they may urinate a lot. But we still want to make sure we watch it because they can have urinary retention, right? And diaphoresis. Oftentimes they'll perspire heavily, and you go in and they put their call on in the middle of the night, and they're like, my bed is soaked, and you have to change the whole linens. So, and tell them that this is something that is normal. Okay, it's okay. This is how you get rid of excess fluid, and oftentimes they'll lose some weight from all of that, of course, a few pounds. Gradually, the cardiac output will go back to its normal state in 6 to 12 weeks. Again, we have increasing clotting factors that help, unfortunately, make it a predisposition to clot formation. So we always have to be aware of that. Of course, right after oftentimes after they've had their baby, they're starving. They haven't had anything to eat or to drink. They've had ice chips, sips of water, maybe during labor, but they're exhausted, and that's why they call it labor. It's hard work, and so they're very hungry. And so, lots of times we don't recommend that they load up on a greasy hamburger and onions and whatever, but we do give them something to eat. And because pregnancy is often one of the complaints women have is they're constipated. They may be taking iron. There may be various factors that cause them to feel and be more constipated. Well, this can be exacerbated during labor because they have decreased food and fluid intake. And there's decreased muscle and bowel tone because of maybe possibly trauma of birth and so forth. And so the one thing we're going to do right away is start them on Colace, a stool softener. We typically don't go to laxatives unless it's really, really indicated. The stool softener, increasing their fluids, the fiber in the diet, and so forth, usually take care of it. The first stool is usually passed in the first 2 to 3 days postpartum or post-birth. We also encourage them to get up and move and walk. That increases peristalsis, and that will help move the stool along as well. Okay. The urinary system, because of the increased bladder capacity and decreased sense to fluid pressure, may result in urinary retention. All right, so we have to watch that urine output very, very carefully because remember, if they've had an epidural and the sensation is gradually returning, they may have feeling in their legs and may even be able to get up and walk. But sometimes they still don't feel that pressure to urinate. And so we really, really need to watch that. And so if they are up and they're trying to void and they're voiding about 100 to 150 milliliters at a time, that's not enough. And so we're going to check them for bladder distension, maybe do a bladder scan. Also remember that the distended bladder displaces the uterus and can interfere with uterine contraction and cause excessive bleeding. That's a very, very important statement. All right. This is also from your book. These are some signs of a distended bladder. The location of the fundus is above the baseline, okay? You massaged it down and it's 2 finger breadths below the umbilicus. And then you go back in and it's displaced to the side and it's above the umbilicus again, all right? We have a lot of lochia. We have a lot of bleeding. It's uncomfortable. Sometimes you can actually see the bulge of the bladder above the symphysis pubis. Don't wait till it gets there. Frequent voidings of less than 100 milliliters, 150 milliliters of urine. Those are all signs of possible urinary retention in your postpartum woman. And the musculoskeletal changes, the first 1 to 2 days after the childbirth, they just feel kind of achy and they feel tired because the muscles have been stretched and moved and all that. They will take time to go back to their pre-pregnant state. The abdominal wall, the diastasis recti, that's where it almost feels like the abdominal wall has kind of split a little bit, the muscle. And so that should go back to what it was. And there's various exercises that women can do to help promote musculoskeletal comfort, if you will, and strengthen the abdominal muscles. And while I'm thinking of it, I can't remember. When I'm thinking about the urinary system, I should have said this on that slide. We encourage women to do Kegel exercises. That's where they actually try to stop and start their urine stream, and they squeeze those muscles, and that rebuilds that pelvic floor muscles. And there's some pictures in your book of different exercises that they can do to help with muscle aches and pains and so forth. The skin gradually returns to its non-pregnant state because of the decrease in hormone levels. The stretch marks will fade, but they do not totally disappear. They will become kind of a white silvery appearance. Sometimes they lose hair a little bit. Some women do, some women don't, but typically it goes back to normal. The neurologic system, they're not going to be disoriented and confused, but they may just have some vague complaints. I'm just so tired, I don't feel good, and they need rest. That's what they need. But if the woman is complaining of a headache, and not just a mild headache, but a severe headache, okay, we need to investigate. Bilateral and frontal headaches are common just because of fluid electrolyte balance changes, okay? So that frontal headache, possibly on the temples, but a spinal headache, often due to a spinal anesthesia, we may have to do a blood patch. And then, these are the key words here. Really bad headache with blurred vision, photophobia, and upper abdominal pain may indicate preeclampsia. So never dismiss those when your patient complains of those. Ask the questions. Do your assessment. Of course, we know that the endocrine system, there's a lot of hormones in play during pregnancy. The HCG is still present for about 3 to 4 weeks, but it goes down to where it should be. After childbirth, women will have a resumption of their ovulation and their menstrual periods. Breastfeeding women may delay the return of ovulation and menses, but ovulation can actually occur before they have their menstrual period, and so they do need to understand that if they have unprotected sex, they can actually have a real close together baby there. So they need to be aware of that just because they're not having menstrual periods does not mean they are not ovulating. This is kind of strange. Okay. And of course, lactation, prolactin initiates milk production, oxytocin is released as well to help stimulate the letdown reflex and so forth. And then we've already talked about the uterine contractions that can happen, or the cramps. Typically, women will lose about 12 pounds during childbirth. That's because of the fetus, the placenta, the amniotic fluid, and then remember we talked about the diuresis and the diaphoresis. After about 2 weeks, they'll lose about 9 more pounds, and then they may lose another 5 pounds or so by 6 months. If they lose that a lot more quickly, they could be having very poor dietary habits, and we need to investigate that. And of course, there's adipose tissue or fat that we use during labor and delivery and so forth. So there may still be some remaining issues with that. They might not be able to get into their skinny jeans. Okay, some women will, but a lot of women will not. They'll have a little bit of flab left over from being pregnant. Okay. So slow number 2 says describe the nursing assessment components and interventions appropriate in the care of the postpartum client. All right. So we are going to, that first 24 hours especially, we're watching this patient closely because the number one problem we're watching for is postpartum hemorrhage. All right. So we're going to watch those vital signs. The vital signs, of course, we include the blood pressure, especially when we first get her mama up out of bed after her epidural has worn off and she says she needs to get up and walk to the bathroom. We're going to check orthostatics. Okay. We've got to make sure we don't have someone fall on the floor. I also recommend that first time that you get your patient up, that you have her stand at the bedside and walk in place. That often will let her know, oh, I'm feeling dizzy, I need to sit down, or no, I feel okay, I think I'm ready to go. And you don't let go of her. You hang on to her. All right. Check that pulse, the respiratory rate, of course, the temperature, and of course, pain is the 5th vital signs. We always ask about that. Definitely. We're going to check that fundus and the amount of lochia and how many pads she's been using and so forth. We're going to look at the perineum. Of course, we said that it may look a little edematous and bruised. But we're going to keep an eye on that. We're going to put the ice packs there for the first 24 hours at least to help with that swelling and discomfort. We're going to check that bladder. We're going to make sure we are keeping an eye on her output. During labor, how many times maybe she got cathed and in and out cath. Some docs will have you put in a Foley and leave it in until she starts to push, and then they'll have you take it out. Just depends on your facility, but we're watching that bladder very, very closely. And as you see here, a lot of this is that bubbly thing that we talked about. The breasts, and within 24, we're ask her if she's breastfeeding or whatever. And we'll know that probably before she delivers. If she is breastfeeding, one of the first things we're going to do, of course, is put baby to breast, skin contact, very, very important. We're looking at those lower extremities for any redness, swelling, one bigger than the other, any pain in those lower extremities. The Homan sign we don't typically check. We ask the woman to put her heel flat in the bed and flex her foot with her toes pointed toward her head. And if she says, "Ooh, that hurts my calf," or she says, "Ooh, that's kind of uncomfortable," then we are going to very carefully look at that calf area, and we're going to palpate for any warmth or red. We're going to look for redness that might indicate the possibility of a clot. All right. We look for edema. Lots of times the edema could be a part of that preeclampsia thing, and we may still be checking DTRs, but probably not. The edema is usually transient. So anything that's unusual here, we want to follow up on and make sure that nothing escapes us and we're not caught not knowing what to do. All right. Our slow number 3, the common medications that we use for the postpartum client. All right, and these are not real hard. Common medicines, okay? We talked about Colace. We use a lot of ibuprofen and Tylenol. She may still be taking iron, ferrous sulfate, until maybe her first checkup or whatever. Prenatal vitamins are continued because especially if she's breastfeeding, she's going to need those. And then, of course, any pain medicines that are not, if the ibuprofen and Tylenol are not effective, we will give some pain medicines. We will give Rogam, that should say an R, not a P, R-H-O, sorry, if indicated. Mother is RH positive, baby is RH negative, especially the first pregnancy. We're going to give that so that we can prevent an RH incompatibility. The MMR, if it's necessary, of course, we can't give that during pregnancy, but once she's had the baby, if she needs it, we can give it then, but we need to tell her that she cannot get pregnant for about 3 months at least, because it can be very teratogenic. Also, local anesthetic agents like Anusol, creams and sprays, Dermaplast spray, Tux pads, all of those are local things that we can use on the perineum as well as the ice to promote comfort. Okay, and so obviously the medications that we just discussed, you should know the side effects. Of course, Colace, if she's having diarrhea, you would want to hold that. Of course, pain medicines like the Norco or whatever have the potential to cause constipation, so we're going to talk to her about that. We're going to talk to her about her pain level, and we're going to get a level there of where she thinks she can tolerate the pain, and then we're going to implement pain medication as needed in that situation. The rest of those, too much Tylenol obviously is going to be poor and bad for your liver. Too much ibuprofen is going to be bad for your kidneys. And typically ibuprofen has what we call a ceiling effect, which we reach the max dose, and if we keep giving it, it doesn't make any difference. So again, lots of times we alternate the Tylenol and the ibuprofen. And there are our references for chapter 20.